We're here at the 2019 ASCO annual meeting talking with Lymphoma Hub about the future of post-transplant maintenance therapies in Hodgkin lymphoma. So the current standard of care in Hodgkin lymphoma, patients who have undergone a autologous stem cell transplant is to use brentuximab vedotin as post-transplant maintenance therapy if they are high risk. And so high risk is defined as having primary refractory disease after frontline therapy, early relapse within a year of completion of frontline therapy, or having extranodal involvement at the time of relapse. And so the presentation today really delved into the data around that study and the recent follow-up, 5-year follow-up data that was presented that showed that the original findings of the study were confirmed, which is that the progression-free survival in patients who received brentuximab vedotin as post-transplant maintenance was improved as compared to patients who received placebo, with a 5-year progression-free survival about 59% as compared to, I believe it was about 41% in patients who had received placebo. Now, the data also showed that it was the patients with the highest risk, the most risk factors that seemed to benefit most from the brentuximab vedotin. And so patients who had 2 or more or 3 or more risk factors really seemed to derive the most benefit, with a progression-free survival in the patients who received brentuximab in about the 60% range. And patients who had 3 or more risk factors who didn't receive brentuximab vedotin maintenance actually had a progression-free survival at 5 years of about 20 or 30%. And so, in the present day, certainly for patients who have not received brentuximab vedotin prior to their stem cell transplant, we typically do recommend maintenance therapy with BV after transplant if a patient is BV naive. Now, the trouble is that most patients nowadays, or at least many patients, will have received brentuximab vedotin prior to the stem cell transplant. So they will have received it as part of frontline therapy or as part of their salvage regimen to get them to transplant. So the dilemma really lies in, how do we apply the prior randomized Athera trial to those patients? I think it's safe to say that patients who are refractory to their prior brentuximab vedotin probably shouldn't get post-transplant maintenance with BV. I think the area where we don't have data, but there may be a rationale to use the drug is when a patient is sensitive to brentuximab vedotin, particularly as their salvage therapy. And if they had a great response to 4 cycles of brentuximab vedotin-based salvage therapy, I think if they meet the Athera criteria, those high-risk criteria, otherwise it would be reasonable to consider using brentuximab vedotin maintenance in those patients. Now, we also discussed the use of PD-1 blockade as part of post-autologous stem cell transplant maintenance. So far, there's been one study, a phase 2 study of pembrolizumab as post-transplant maintenance in patients with Hodgkin lymphoma that was had promising results, progression-free survival at 19 months of 81%. And so, it was only 30 patients. It was a more favorable risk population than the Athera trial. So while we wouldn't recommend using pembrolizumab as post-transplant maintenance routinely, I think it's, the data are promising and suggest that we should study the regimen further in patients with Hodgkin lymphoma who undergo a transplant. There are other studies that are currently ongoing. The one that we're leading at City of Hope, which is a multi-center trial using brentuximab vedotin and nivolumab combined as post-auto transplant maintenance, and so you may envision a future where whether or not a patient, what type of post-transplant maintenance a patient receives depends on what their exposure to novel agents is prior to transplant. So if they've had BV but they're refractory, perhaps they'll get PD-1, anti-PD-1 based maintenance, post-transplant maintenance. If they're refractory to PD-1 blockade, maybe they'll get brentuximab as post-transplant maintenance. If they're naive or sensitive to both types of novel agents, maybe they'll get a combination post-transplant maintenance with both agents.